Welcome back to the deep dive. We are here to give you that shortcut, slicing through the dense stuff to get to the heart of what matters. Today, we're tackling something really fundamental. It's about the body's response when things go wrong locally, but the reaction goes, oh, global. We're diving into that feeling, that deep, miserable sickness when you have the flu, maybe. It's not about the cut on your finger. No, it's about the full body experience, the fever, the aches, the just total exhaustion. That feeling tells you your entire body is fighting, even if the problem started small, like a scrape.
Exactly. And that whole coordinated effort has a name, the acute phase response, or APR. It's really quite amazing when you look at it. Inflammation might start in one spot, but the APR involves this huge systemic shift. And it's driven by chemical messengers, proteins called cytokines. So our goal today is to really unpack how the APR works. We'll look at the main cytokines, TNF, IL-1, IL-6, these are like the commanders. And we'll trace how they influence everything, from what your liver is making to your brain setting your body temperature. We want to get past just the symptoms.
Okay, let's unpack this then. And probably the best place to start is the one sign everyone knows, the fever, right? The fever. Your temperature shoots up, maybe 4 degrees Celsius higher than normal. And for you listening, remember, this isn't just something that happens. The body is choosing to do this. It takes energy. So why? Why does the body deliberately crank up the heat? What's flipping that switch?
It is absolutely deliberate.
Yeah.
And the whole process involves things called pyrogens. These are basically fever-inducing substances. And we need to split them into two groups, really. First, you've got exogenous pyrogens. These come from outside the body. Think bacterial products. A big one is LPS, lipopolysaccharide. It's part of the cell wall of certain bacteria. When your body detects LPS, it's a major danger signal.
Okay, so invaders bring their own alarm bells.
Pretty much. Then you have the endogenous pyrogens. These are the body's internal signals. Mostly, we're talking about those cytokines we mentioned, IL-1 and TNF. So here's the chain reaction. The exogenous pyrogens, like LPS, they trigger your immune cells. Macrophages are key players here to just flood the system with IL-1 and TNF. And it's these circulating cytokines, the endogenous ones, that travel up to the brain and start the whole temperature change process.
Okay, so IL-1 and TNF carry the red alert message to the brain's control room, the hypothalamus. But how do they get that message across? Isn't the brain usually quite protected?
That's a great question. They don't necessarily cross the blood-brain barrier directly in large amounts. Instead, they act on cells right there in the hypothalamus, specifically the vascular cells, the blood vessel walls, and the cells surrounding them. This area is the body's thermostat, basically. It keeps our temperature stable. So when IL-1 and TNF bind to receptors on these hypothalamic cells, it sets off a chemical cascade inside those cells.
A cascade that leads to...
It leads to the upregulation, meaning making more of enzymes called cyclooxygenases. You probably know them as COX enzymes.
Ah, COX enzymes, like the ones targeted by aspirin and ibuprofen.
Exactly those.
Yeah.
So these COX enzymes start churning out these potent lipid signals, specifically a prostaglandin called PGE2, prostaglandin E2. And once PGE2 is made there, right in the hypothalamus, it stimulates neurotransmitters. And those neurotransmitters effectively tell the body's thermostat to reset itself to a higher temperature.
Wow. So it's like someone sneaks into the control room and just cranks the dial up.
That's a perfect analogy. The body now has a new, higher target temperature it needs to hit.
And that's where all the misery comes from, isn't it? The shivering, the feeling cold even when you're burning up. The body's trying to reach that new set point.
Precisely. It has to do two things. Stop losing heat and start making more heat. To stop losing heat, it clamps down the blood vessels near the skin. That's peripheral vasoconstriction. Blood gets shunted away from the surface.
Which is why your skin feels cold and you get the chills.
Exactly. You feel cold because your surface is colder, even if your core is heating up. Then, to generate heat, the body kicks brown fat into gear and, more noticeably, triggers muscle contractions. That's the shivering, or rigors. Those intense muscle spasms burn a lot of energy and generate heat internally.
So it's this internal battle. Your body is fighting to meet the command set by PGE2 in the hypothalamus.
And it keeps doing that until the core temperature reaches the new, higher set point.
Okay, so why do we put up with this? Evolutionarily speaking, the idea is that fever helps, right? Maybe slows down bugs, speeds up our own defenses.
That's the general thinking. We see fever across many species, even cold-blooded ones who will physically move to warmer spots when infected. So it's assumed to be protective. Maybe it enhances immune cell function, maybe it inhibits microbial growth, maybe both.
But often the fever itself is so rough, we step in. And that's where those NSAIDs come back in.
Yes. Drugs like aspirin, ibuprofen, the non-steroidal anti-inflammatories, NSAIDs, they work directly on this pathway. They reduce fever because they inhibit those COX enzymes. By blocking COX, they stop the production of PGE2 in the hypothalamus. No PGE2 means no signal to reset the thermostat, so the body temperature just drifts back down towards normal.
It's a very targeted way to break the cycle.
It really is. It shows just how critical that PGE2 molecule is for the whole fever response.
And just quickly, you mentioned COX enzymes. There are different types, right? COX1, COX2. Does that matter for fever?
It does, more for side effects, usually. COX1 is involved in things like protecting your stomach lining. COX2 is often more involved in inflammation and fever. Many common NSAIDs block both. That's why they can sometimes cause stomach upset with long-term use. They're blocking the protective COX1. But for reducing fever, the key is just stopping that PGE2 production in the brain, which likely involves COX2 primarily, but blocking either relevant COX can work.
Got it. So effective, but sometimes there's a cost.
Okay, so beyond the brain resetting the temperature, the next huge systemic event happens in the liver. It completely changes its manufacturing priorities. It starts massively churning out a specific set of plasma proteins. We call these the acute-phase proteins, or APPs.
And when you say massively, you mean it. The source mentions increases of hundreds of times normal levels. This isn't a minor tweak.
Not at all. It's a full-scale mobilization. And the main signal telling the liver cells, the hepatocytes, to do this is another cytokine. Interleukin-6, IL-6, often IL-1 and TNF plays supporting roles too.
So IL-6 is the foreman shouting new orders in the liver factory. What are the main proteins coming off this new production line?
Let's focus on the big three. First, you have C-reactive proteins, CRP, and serum amyloid A, SAA. Think of these as the first wave of reinforcements sent out by the liver.
CRP and SAA. What's their mission once they hit the bloodstream?
Their job is to find and help neutralize threats. They're what we call pattern recognition molecules. They're good at binding to the surfaces of microbes, bacteria, fungi, parasites.
Okay, they grab onto the bad guys. Then what?
Once they're bound, they do a couple of really important things. First, they act as opsonins.
Opsonins. That means they tag the microbe, right? Like putting a kick-me sign on it for the immune system?
Huh. Yeah, basically. It makes the microbe much easier for phagocytic cells, like macrophages, to recognize, grab, and destroy. Eat this, like you said earlier. Second, they help activate the complement system. That's another cascade of proteins in the blood that can directly kill microbes by punching holes in them, among other things.
So taggers and activators. Versatile.
Very. And they also have a cleanup role. CRP and SAA can bind to chromatin.
Chromatin, that's the DNA and protein package from inside our own cells.
Exactly. When our cells get damaged or die messily, like in necrosis, they spill their guts, including chromatin. CRP and SAA bind to this debris, which helps the body clear it away efficiently. This might help prevent the immune system from reacting against our own DNA, which could lead to autoimmune problems.
Okay, so tag, activate, cleanup. Got it. What's the third major APP you mentioned?
Fibrinogen.
Fibrinogen. I usually think of that in terms of blood clotting. How does it fit into inflammation?
It's definitely key for clotting, but during the APR, its levels shoot way up too. And this high level of fibrinogen is actually the reason behind a very common, simple lab test for inflammation, the ESR.
ESR, erythrocyte sedimentation rate. Right. How does fibrinogen affect that?
Normally, red blood cells have negative charges on their surface, so they repel each other. But the fibrinogen, when there's a lot of it, kind of coats the red cells and masks those charges. So the red cells stop repelling each other and start sticking together. They form these stacks, like piles of coins. The technical term is rouleau formation.
Okay, they clump up.
Exactly. And these heavy clumps, these rouleaux, fall through the plasma in a test tube much faster than individual red cells would. So the distance they fall in a set time, the augmentation rate goes up.
Ah, so a high ESR doesn't directly measure the infection. It measures the high fibrinogen level caused by the inflammation. It's an indirect sign that the APR is active.
Precisely. It's not specific to what's causing the inflammation, but it tells you that inflammation is happening systemically. A very useful, simple indicator.
Okay, now, here's where it gets really interesting and maybe a bit concerning. These APPs are good guys in the short term, right? Helping fight infection. But the source material makes it clear that if this goes on too long, trouble.
Big trouble. This is the dark side of the APR. Take SAA, serum amyloid A. It's great for acute response, but if you have chronic inflammation, maybe from an autoimmune disease or a really persistent infection that the body just can't clear, The liver keeps pumping out SAA at high levels for weeks, months, years.
And that's bad because...
Because SAA protein, over time and at high concentrations, has a tendency to misfold. It changes shape into an abnormal form.
Right.
And these misfolded SAA proteins stick together, forming these tough, insoluble fibers called amyloid fibrils. These fibrils then deposit in various organs.
Deposit where?
Mostly in the kidneys, but also the liver, spleen, heart. And they physically clog up the tissues, interfering with normal function. This condition is called secondary amyloidosis.
Secondary because it's caused by the underlying chronic inflammation.
Exactly. And it can lead to serious organ damage, even organ failure. It's a devastating long-term consequence where the body's defense protein literally becomes toxic.
Wow. That really underscores the danger of unresolved inflammation. But the liver's influence during the APR doesn't stop there, right? It also controls key resources, affecting blood counts down the line.
Yes, it manages resource allocation. And a key player here is a protein called hepcidin.
Hepcidin, what does that do?
Hepcidin's levels go way up during inflammation, driven by IL-6. And hepcidin is the master regulator of iron in the body. Its job during inflammation is basically to hide the body's iron.
Hide it. Why?
To starve the microbes. Most bacteria need iron to grow and multiply, so the body tries to make iron less available in the bloodstream.
How does hepcidin hide the iron?
It blocks iron from getting out of cells. It traps iron inside macrophages, which recycle iron from old red blood cells, inside liver cells, which store iron, and very importantly, it blocks iron absorption from your diet in the gut cells.
So less iron circulating for bugs to use. Makes sense as a defense.
It does, but again, there's a long-term cost. If inflammation persists and hepcidin stays high, the bone marrow can't get enough iron.
And the bone marrow needs iron to make.
Hemoglobin, the protein in red blood cells that carries oxygen. So even if the body has plenty of iron stored away, it's not accessible to make new red blood cells. This leads to a specific type of anemia called the anemia of chronic inflammation or anemia of chronic disease. It's a major cause of fatigue and weakness in people with long-term inflammatory conditions.
Another example of a short-term defense causing long-term problems. And the liver's not done yet. It also ramps up clotting factors.
Well, not just factors, but the stimulus for platelet production. The liver increases its output of thrombopoietin.
Thrombopoietin sounds like it makes thrombocytes, which are platelets.
Exactly. Thrombopoietin is the main signal telling the bone marrow to make more megakaryocytes, which are the giant cells that fragment to produce platelets. So during sustained inflammation, you often see the platelet count go up. This is called thrombocytosis.
And more platelets means increased risk of clotting.
Potentially, yes. It contributes to a prothrombotic state. So again, a local inflammatory trigger leads to a systemic change that could increase the risk of dangerous blood clots forming somewhere else entirely. Okay, so the liver's handling the chemical warfare side. The bone marrow, meanwhile, is ramping up troop production and deployment. The most common sign of this is leukocytosis.
Leukocytosis just means a higher number of white blood cells, right? Leukocytes.
Right, especially with bacterial infections, you see the white count jump. Normal might be, say, 4,000 to 10,000 cells per microliter. In infection, it can easily go to 15,000, 20,000, sometimes even higher.
What drives that surge? How does the marrow respond so fast?
It's a two-stage process, really.
Yeah.
First, there's an immediate effect from those initial cytokines, TNF and IL-1. Within hours, they signal the bone marrow to release its stored reserves of mature white blood cells, especially neutrophils. It's like opening the barracks doors and sending out all the trained soldiers right away.
Quick deployment of existing forces.
Exactly. But if the infection hangs around, the body needs to make more soldiers. That's the second stage. Immune cells, like macrophages and other cells in the inflamed tissues, start releasing different signals called colony-stimulating factors, or CSFs. These CSFs tell the precursor cells in the bone marrow, the stem cells, to start dividing and maturing into new white blood cells. Again, mainly neutrophils, much faster. This sustains the supply for a longer fight.
So release the reserves first, then boost production. Makes sense. Now, this accelerated release leads to something doctors look for called the shift to the left. It sounds like jargon, but it's really informative. Can you break down what that means?
Sure. Imagine the production line for neutrophils in the bone marrow. You start with very immature cells on the left side of the diagram, and they mature in stages as you move to the right, ending with the fully mature segmented neutrophil.
Okay, like a conveyor belt from rookie to veteran.
Good analogy. Normally, only the mature veterans get released into the blood, but when the demand is incredibly high, like in a bad infection, the bone marrow gets pushed to release cells faster. So it starts letting out not just the fully mature ones, but also some of the slightly less mature forms, the ones just before full maturity, often called bands, or sometimes even earlier stages like metamyelocytes. These are the rookies from your conveyor belt.
So shift to the left means you're seeing more of these immature forms, these rookies, in the bloodstream than usual.
Precisely. It tells you the bone marrow is under pressure, rushing production and release. It's a sign of significant inflammatory stress, usually bacterial infection.
And this is why looking at the types of white blood cells, the differential count is so useful, right? The pattern can hint at what kind of invader the body is fighting.
Absolutely. The differential is key. If you see mainly neutrophilia, a high number of neutrophils, including that shift to the left, you strongly suspect a bacterial infection. Neutrophils are the main bacterial fighters. If instead you see lymphocytosis and increase in lymphocytes, T cells and B cells, that points more towards a viral infection. Think infectious mono, mumps, German measles. And if you see eosinophilia, lots of eosinophils, you start thinking about allergic reactions or, classically, infections with parasitic worms, helminths.
So the body tailors its response, and we can see the fingerprint of that in the blood count.
We can. But it's also important to remember that sometimes the white count actually goes down. That's leukopenia.
Down. Why would that happen during an infection?
Yeah. It can happen in certain severe infections like typhoid fever or some viral and other types of infection. It might be because the white cells are being destroyed or because they're all rushing out of the blood and into the tissues where the fight is, so they're just not being picked up in the blood sample. Or maybe the marrow production itself is suppressed by the infection. So a low count doesn't always mean no infection. Sometimes it means a particularly nasty one.
Okay, let's shift gears a bit and talk about how all this feels. Because beyond the fever and the lab tests, there's that overwhelming sense of just being sick. The malaise, the sleepiness, the total lack of appetite, the aches. It's kind of mind-blowing to think this profound feeling of awfulness isn't just random misery, but actually another programmed part of the APR.
It absolutely is. Those feelings, the general discomfort, malaise, the anorexia, loss of appetite, the somnolence, drowsiness or sleepiness, they're all thought to be directly caused by cytokines like IL-1 and TNF acting on brain cells.
And presumably there's an adaptive reason for making us feel so terrible.
The thinking is yes, it's about conserving energy. Fighting infection takes a huge amount of metabolic resources. Think about maintaining a fever, producing all those APPs, making billions of new white blood cells. It's incredibly costly. So the body effectively shuts down non-essential activities. Making you feel tired discourages physical activity. Loss of appetite reduces the energy spent on digestion. It forces you to rest and redirects all available fuel to the immune system.
So feeling wiped out and not wanting to eat is actually your body trying to help you survive by focusing resources.
That's the hypothesis. It's a survival strategy, even though it feels dreadful.
And we also see other physical changes, right? Like changes in heart rate.
Yes, often you get an increased pulse rate and sometimes slightly higher blood pressure. The cardiovascular system is working harder, partly due to the fever and increased metabolic rate.
Yeah.
And related to the fever, you also tend to see decreased sweating. Remember that vasoconstriction, pulling blood away from the skin to conserve heat.
Right, to help reach the higher temperature set point.
Well, reducing sweating is another way to minimize heat loss from the skin surface. So all these things, the chills from vasoconstriction, the shivering to generate heat, the fatigue, the appetite loss, the reduced sweating, they are all interconnected pieces of this coordinated systemic response orchestrated by cytokines.
Okay, we've talked about the body's coordinated response, but what happens when that response goes completely off the rails? When the defense becomes more dangerous than the threat? That brings us to septic shock. If the APR is the fire alarm and sprinkler system, septic shock is the building collapsing from the water damage and the fire raging out of control. Here's where it gets really frightening.
That's a good way to put it. Septic shock is the most severe manifestation of what's called systemic inflammatory response syndrome, or SIRS. It's usually triggered by a really severe bacterial infection, sepsis, where huge amounts of bacteria, or their components like LPS, get into the bloodstream. This massive load of microbial triggers causes an absolutely overwhelming, uncontrolled release of those pro-inflammatory cytokines, especially TNF and IL-1. It's often called a cytokine storm. And at these incredibly high concentrations, the cytokines stop being helpful signals and become directly damaging to the body's own tissues, leading to widespread physiological collapse.
Collapse how?
Sure.
What specifically do these sky-high TNF and IL-1 levels do that's so catastrophic?
They cause a devastating combination of effects, often described as a clinical triad. First, they hammer the blood vessels. High TNF causes systemic vasodilation. Blood vessels everywhere relax and widen, At the same time, they dramatically increase vascular permeability. The vessel walls become leaky. Fluid pours out of the bloodstream and into the tissues.
So blood pressure plummets.
Exactly. You get a catastrophic drop in blood volume and vascular resistance. This is hypotensive shock. Blood pressure falls so low that vital organs don't get enough oxygen and nutrients. That's the first part of the triad.
Okay, circulatory collapse. What's the second part?
The second is disseminated intravascular coagulation, or DIC. This is incredibly dangerous. The high cytokine levels, along with endothelial damage, trigger the clotting system everywhere, all at once. Tiny blood clots start forming throughout the microcirculation, the small vessels in the lungs, kidneys, brain, everywhere.
So widespread clotting. But the name implies coagulation and bleeding. How does that work? It seems paradoxical.
It is paradoxical, but it makes sense biochemically. This uncontrolled body-wide clotting uses up all the available clotting factors and platelets incredibly fast. The liver and bone marrow just can't keep up with the demand. So once the clotting factors and platelets are depleted, the body loses its ability to form clots at all. The patient then starts bleeding uncontrollably, even from minor sites, while still having those microclots blocking vessels and damaging organs. It's the worst of both worlds. Pathological clotting and pathological bleeding happening simultaneously.
Other chaos in the blood system. And the third part of the triad.
Profound metabolic disturbances. Septic shock often causes severe insulin resistance. The body's cells can't use glucose properly even though metabolism is running high. This often leads to hyperglycemia, very high blood sugar, which itself adds to the organ damage. So you have circulatory collapse, clotting and bleeding chaos, and metabolic breakdown all happening at once. It's why septic shock has such a high mortality rate. The body's own defense system, pushed into overdrive, becomes the agent of destruction. #tag2, updates, references, and broader implications. Now, if we step back and connect all this detailed mechanism to the bigger health picture, it's become really clear that understanding the APR isn't just about understanding acute infections like the flu or sepsis. These same inflammatory pathways, these same markers like CRP, are deeply implicated in many major chronic diseases. Inflammation isn't just a reaction anymore. We see it as a driver.
Right. We're moving from acute defense to long-term risk, and the link between C-reactive protein, CRP, and heart disease was a huge shift in thinking, wasn't it?
Absolutely massive. For years, heart disease, atherosclerosis, was mostly seen as a plumbing problem, cholesterol clogging the pipes. But over the last, say, 20 years or so, research piled up showing that even slightly elevated levels of CRP in the blood levels, much lower than an acute infection but persistently high, are a strong predictor of future risk for myocardial infarction, heart attack, especially in people who already have some coronary artery disease.
Okay, so why? How does an inflammation marker predict a heart attack? What's the connection between CRP and those cholesterol plaques?
It points to atherosclerosis itself being an inflammatory disease at its core. The thinking is that chronic low-grade inflammation, reflected by that elevated CRP, makes the atherosclerotic plaques unstable. These plaques are buildups of cholesterol, cells, and debris in the artery wall. When they're inflamed, they're more fragile, more likely to rupture or crack open.
And if a plaque ruptures,
its contents spill into the bloodstream inside the artery, and that triggers a massive clotting response right there on the spot. A thrombus, a blood clot, forms, and that's what blocks the artery suddenly, causing the heart attack or stroke. So a high CRP level is like a warning sign that there's ongoing inflammation simmering within those plaques, making them dangerous. Systemic inflammation becomes a direct risk factor for acute cardiovascular events.
that completely reframes heart disease risk. It brings us back to that core idea we keep hitting. The protective response having a dangerous flip side.
It's the central theme, isn't it? Every part of the APR evolved for short-term survival. Fever helps fight bugs, CRP clears debris, hepcidin hides iron, fantastic in the short run. But we've seen the consequences of chronic activation. SAA causes amyloidosis, hepcidin causes debilitating anemia, and even things like the sustained increase in platelets thrombocytosis driven by thrombopoietin.
That creates a generally higher risk of unwanted clotting, right? Like deep vein thrombosis or clots leading to stroke.
Exactly. The body ramps up clotting potential globally to deal with potential local damage. But that systemic change carries its own risks if it goes on too long.
So the crucial difference between defense and disease often just comes down to duration. Can the body switch it off?
That seems to be the key. If the initial trigger for inflammation isn't removed quickly, or if the off signals don't work properly, the very systems designed to protect you can start causing chronic damage.
The take-home message for you listening seems to be that acute inflammation and chronic disease aren't separate worlds. They operate using the same fundamental biological pathways. #tag outro. So, wrapping up this deep dive, we've really journeyed inside the body during illness. We've seen that the fever, the aches, that profound sense of malaise, it's not random. It's a highly orchestrated, system-wide defense strategy run by those powerful cytokine messengers, TNF, IL-1, and IL-6. We've traced how this strategy plays out. The liver switching production lines to make APPs like CRP and fibrinogen, impacting everything from microbial defense to blood tests like the ESR, but also carrying risks like amyloidosis and anemia. We saw the bone marrow mobilizing troops, leading to leukocytosis and that revealing shift to the left. And we saw how, pushed too far, this response collapses into the catastrophe of septic shock.
Which brings us to our final thought for you, building on everything we've discussed. We used to think of symptoms like fatigue or general malaise as maybe vague, subjective things, but now we can trace them back to specific molecular events, to cytokine actions. And we know these same inflammatory processes link directly to major chronic diseases, heart disease, anemia, maybe others we're still discovering. So consider this, that persistent low-level feeling of being unwell, maybe that nagging fatigue or unexplained aches. Could that be your body's acute phase response simmering on low heat? Could subtle chronic inflammation, driven by these ancient defense pathways, be quietly shaping your long-term health right now? Something to think about.